Hi, good afternoon, everyone. I'm glad to be back in person. And for those of you who don't know me, I round at University Hospital on the consult service sometimes, but most of the time I spend in our glomerular disease clinic where I see all kinds of rare cases. And I've had a few of you on your ambulatory rotations rotate through there. So it's a pretty exciting clinic. I'm always happy to have you guys rotate through to see these diseases that you don't get a chance to see very often, and you read about in the books, but I have quite the cohort of patients, so love to share those cases with you. So today I tried to divide it because it's such a big topic. I'm going to be focused mostly on nephrotic syndrome. I know Dr. Krishnan, and this is a wonderful kidney day. I'm actually wearing orange. Orange is the color of kidney disease awareness. So I thank Dr. Krishnan for her previous lecture, and I know she did touch up on some of the glomerular diseases that are associated with acute kidney injury, and we'll be going into more detail on those as well. So, but most of those we'll cover next week. So to start off, I have this lovely picture. So we have kind of a cartoon here of the glomerulus, so where a majority of acute kidney injury is from tubular injury, as you guys just heard about. Glomerular diseases are primarily associated with proteinuria, hematuria, can be associated with acute kidney injury, but are much less common. So here you have a picture of the glomerulus and those lovely capillary loops. And I really like this because this is what we call a scanning EM picture, where you can actually see the podocyte wrapping around those capillary loops, kind of forming those foot processes in more like a 3D image. So you can really see how the podocyte is so essential to maintaining basically the maintaining normal function of the kidney and the glomerulus. So when the podocyte is sick, you have the leakage of protein into the urinary space. Here is what podocytes look like on regular electron microscopy. So they should be kind of upright, looking nice, and here's what they look like on a nephrotic patient. So they're effaced, and we talk about this frequently. So, I'm trying to click forward here. Okay, there. The arrows didn't work, so I'll use the mouse. So this is just kind of a general, obviously there's a lot of overlap, but nephrotic versus nephritic syndromes, just some of the common classifications that we see. And the focus of today's talk is primarily going to be primary nephrotic syndrome. So minimal change disease, focal segmental glomerular sclerosis, which I will be calling FSGS for the rest of the talk, and membranous nephropathy. Obviously, more common, we see patients with nephrotic range proteinuria to have these systemic diseases. So diabetic nephropathy, probably the most common cause of nephrotic range proteinuria, and sometimes nephrotic syndrome. Amyloidosis, multiple myeloma, also can present with nephrotic syndrome. We'll be going over the nephritic syndromes next week, so I'm going to skip over them today. So what is nephrotic syndrome? So a lot of times you hear nephrologists talk about nephrotic range proteinuria and nephrotic syndrome separately, because nephrotic syndrome, by definition, is a syndrome and has more than one factor. So typically protein excretion greater than 3 to 3.5 grams per day, but it also is accompanied by edema, hypoalbuminemia, hyperlipidemia, and lipiduria. And this is something that tests like to ask about. So here you can see an oval fat body, and if you look under a specific light, you get these Maltese crosses. Pretty cool looking. So the three main categories of primary nephrotic syndrome that we see in adults include minimal change disease. And if anyone's med peds out there, you're probably like, wait a second, that's a pediatric disease. Why are we talking about it in medicine lectures? So minimal change disease, of course, is more common in children, but it is seen in adults, and I have several adult patients with this. I have both patients that came from pediatrics, so they were diagnosed as children or adolescents and become adult patients. And then I've also had patients that were diagnosed as adults, primarily in young adulthood, but occasionally you have these outliers. So patients don't always read the book, so we have to have kind of an open mind when assessing a patient. With minimal change disease, sometimes they can have a normal to even low normal blood pressure on presentation, as opposed to FSGS, which typically presents with a high blood pressure. Although sometimes those categories are difficult to delineate. In adults, compared to children, which most minimal change in children isn't biopsied, they're just treated as with steroids. But in adults, anyone with nephrotic syndrome should be biopsied. So in adults, they're often steroid resistant or steroid dependent, meaning that once you try to titrate the steroids down, they relapse. So it can be a much more challenging disease to treat, where we typically think minimal change disease in children tends to be more benign. So FSGS, and both of these, all three of these diseases involve injury to the podocyte. Minimal change and FSGS are considered in the category of podocytopathies because they're characterized by abnormal podocytes and podocyte damage, but there's no immune complex or immune complex deposition or damage. We don't actually know what the circulating factor that's damaging the podocyte is, but we'll go into that in more detail. So FSGS can be primary, secondary, and genetic, and those categories are kind of sometimes harder to tease out than you may think, and we'll go over a little bit more of that because it really has implications when it comes to treatment. It is more common in adolescents and younger adults. And really interestingly, so anytime we see minimal change disease in an adult, we might consider that they have unsampled FSGS. So FSGS, of course, is characterized by podocyte injury, and you get that classic injury on electron microscopy, but if you only have 10 glomeruli on a biopsy, or even less than that, you might be missing the ones that are segmentally scarred, so a patient might look like they have minimal change, but really have FSGS, and sometimes on a later biopsy we'll see that. Finally, membranous nephropathy, which now we used to call it primary idiopathic because we didn't know the cause, but now we're understanding that more and more of these patients have antibodies to specific podocyte proteins. So 70% of patients with what was previously called idiopathic membranous nephropathy have antibodies to the PLA2R protein, so phospholipase A2 receptor. And if you've been in my clinic, I get these levels all the time in these patients that have PLA2R mediated disease. Or secondary, which malignancy and other autoimmune diseases accompany that. And really, and this is for your boards, that you really need to kind of note this patient picture. So membranous, as opposed to minimal change in FSGS, is more commonly associated with middle-aged adults. So typically, they give you that kind of question on a board exam. So what are some of the abnormalities associated with nephrotic syndrome? So we've already kind of gone over edema and hyperlipidemia, increased risk of cardiovascular disease. Infection is a big one, and not just because of the treatment. Basically, when you're severely nephrotic, you're more prone to infection. It's a immunosuppressed state. Endocrine abnormalities. So I had a patient with membranous nephropathy, and I always like these ones that get diagnosed kind of weird. So they were originally diagnosed with hypothyroid, and they had the edema, and luckily our endocrinologist checked the urine and saw they were severely nephrotic, so then they came to nephrology. So sometimes endocrine abnormalities can be a a sign of nephrotic syndrome. Anemia, acute renal failure, typically in patients that are nephrotic, they get acute renal failure from ATN, so acute tubular injury, because of reduced flow. If they're so, they can have essentially hypovolemia even though they're hypervolemic from reduced oncotic pressure, especially in the very low albumin state. And then renal vein thrombosis, and we'll talk about that because these patients, especially patients with membranous nephropathy, are prone to thromboembolism. So some of the mechanisms of thromboembolism in patients with nephrotic syndrome are that there are increased thrombophilic factors. So you have increased factor 5, factor 8, von Willebrand factor, and fibrinogen. Part of this is because of both increased production and also some of these proteins are typically, or some of these are bound to albumin, and in the low albumin state you have higher circulating levels. And then you lose antithrombin 3, and there have been a lot of studies confirming that, possibly also protein C and protein S in the urine. So you have kind of this combination of increased factors for clotting, decreased anti-clotting factors, and then you can also have elevation of platelets and increased platelet aggregation. So I'd like to interject with a question because I want to get you guys involved. You know, it's after lunch. So I'll start by reading the case. So this is a 75-year-old man with a 6-month history of nephrotic syndrome that has a sudden onset of flank pain, hematuria of 18 hours duration. 3 months ago, his creatinine level was 1, 24-hour protein excretion was 3 grams. At that time, he began treatment with an ACE inhibitor and a loop diuretic. On physical exam at this time, blood pressure is 170/90. He was not orthostatic. Cardiac exam reveals an S4, normal S1, S2, with a systolic murmur. The lungs are clear. He has hypertensive retinopathy, and the abdomen is soft with no masses. These are the labs. So he has a creatinine of 2. So we know from a creatinine of 1 a month ago, so that meets the definition of acute kidney injury. He has hyperlipidemia, and on urinalysis, there are 5 erythrocytes, numerous oval fat bodies, no leukocytes, and 15 gram of protein on 24-hour excretion. So what do you think is the most likely cause? Overaggressive diuresis, renal artery stenosis, renal vein thrombosis, or kidney stones? And I'll take any answers. I don't know. Is there a chat feature? I don't know how to look. Okay. I guess I can open the chat box. So that's a great thought. So we have kidney stone in the audience. So the actual answer is renal vein thrombosis. I can totally see why you would think kidney stone. The big thing on this is, so he has 5 red blood cells. Really with a kidney stone, you'd expect to have more gross hematuria. But certainly a kidney stone could present similarly. The reason why overaggressive diuresis and renal artery stenosis don't really fit is both of those are pretty painless conditions, so you shouldn't have pain. But with renal vein thrombosis, patients actually do present with pain. And the setup here really is that the patient has nephrotic syndrome. So that's what they're looking for. Yeah, I think the kidney stones was a good throw in there. But typically with that, you wouldn't see, patients with nephrotic syndrome can get kidney stones, but typically you'd see more hematuria. So part of doing these board style questions is like, what are they trying to get at? So trying to read the minds of the question writer. So this is very classic. A lot of times they'll even throw out that the patient had, membranous nephropathy because that's more associated with thrombosis than the other forms of nephrotic syndrome. All right, so I have another question. And in the sake of time, I might just go through this one really quickly. So this is a 21-year-old female evaluated for edema, facial and lower extremity edema of 1 week's duration. So this is kind of what we see in nephrotic syndrome, a fairly sudden onset. Usually the edema is severe enough that patients seek help. Not always, but most of the time. On physical exam, blood pressure is 90/55. She has periorbital edema and 2+ lower extremity edema. Creatinine's normal. Cholesterol is elevated, albumin's low, normal complement levels, and then you have this 3+ protein on your analysis with numerous oval fat bodies and 15 grams on 24-hour. So you can see on here all the causes of nephrotic syndrome: minimal change, membranous, FSGS. MPGN can present with nephrotic range proteinuria, but usually you'd have more red blood cells. Same with lupus nephritis, unless you're talking about class 5. So I think what they're trying to get at is this patient has minimal change. And it's kind of the best answer. Obviously, you know, as a nephrologist, I'm biopsying this patient. I'm not assuming, even if they fit this picture, that they have this diagnosis. So I'm going to talk a little bit about minimal change disease. So this is a normal capillary loop, and this is what minimal change looks like. So you have this foot process effacement that we saw earlier, and we see this pretty much with anyone with nephrotic syndrome. Really, the rest of the biopsy looks normal. You don't actually see this until you get to the electron microscopy, and that's why it's called minimal change disease. So there can be secondary causes. So drugs, NSAIDs are up there as one of the more common. Malignancies, and I really want to highlight here that the malignancies are more likely hematologic malignancies, so Hodgkin's disease, lymphoma, leukemias, where membranous, which we'll be talking about later, is more associated with solid organ malignancies as a secondary cause. Also, graft versus host, and interestingly, food allergy and bee stings can be associated with the onset of minimal change. So how do we treat this? So prednisone is the first-line treatment, usually 1 milligram per kilogram per day, and you don't want to continue this really, really high dose for more than a 16-week period. We usually start tapering about 2 weeks after complete remission is achieved, although that can be somewhat variable. And the tapering process is usually over a 6-month period. Alternative therapies, so I have a lot of patients with obesity, prediabetes, even diabetic patients that you don't necessarily want to put on high-dose steroids. So you could use a calcineurin inhibitor, so cyclosporin or tacrolimus. The treatment time typically is a little bit longer, at least 12 months, because if you taper too early, they can relapse. And finally, combined administration of prednisone and cyclophosphamide, usually for a 3-month period. We reserve these for really severe cases, if steroid dependent or resistant. And any treatment that includes cyclophosphamide, especially in young patients, you have to counsel on the risk of gonadal toxicity. So some patients opt not to have this therapy regardless. So really don't use this regimen very often, just kind of as a last ditch. So this is from the KDIGO 2021 guidelines, and I can actually send this out. I have a copy of the PDF because a lot of the stuff in both of these lectures I'll be referring to them. So they updated their glomerular disease guidelines in 2021. The previous ones were from 2012, so a lot of things are kind of coming up to date. And this kind of gives you this algorithm. So if you are a frequent relapser, steroid-dependent minimal change disease, cyclophosphamide generally is preferred as long as there's no patient preference. But if the patient wishes to avoid cyclophosphamide, these are some of the other options. So calcineurin inhibitors, mycophenolate, rituximab, which is much more likely to work in someone that was steroid responsive. So another question. So this is a 34-year-old asymptomatic black man who's evaluated for peripheral edema of several months. Medical history unremarkable. Heart rate 79, blood pressure is 140/90. He has an excellent health, appears muscular, but there is 2+ lower extremity edema, and the remainder of the exam is normal. I guess if you have edema, you really shouldn't be called asymptomatic, but I didn't write this question. So creatinine is 1.8, albumin is 3. Again, urinalysis with 3+ protein, several oval fat bodies. And the urine protein to creatinine ratio, this is actually a typo. I thought I had corrected it, so I apologize. So it's should say on there 3 grams per gram, not milligram per gram. And actually, this gives me a good point. When you're doing urinary protein to creatinine ratios, really pay attention. I actually see this in papers all the time where they clearly do not mean milligram per gram. This should be 3,000 milligrams per gram if you're trying to do the equivalent of 3 grams per day. And sometimes we do use that terminology, milligram per gram, if we want to be more exact, but 3,000 would be the equivalent of 3 grams. So pay attention to your units. I get that question a lot, like, what does this mean? Because a lot of times the labs will present microalbuminuria in different units than the protein to creatinine ratio. So which of the following is the most likely diagnosis? So in this case, FSGS is more likely based on the age of the patient presenting with nephrotic proteinuria, although obviously we would biopsy this patient to confirm it. The other clue is that this patient was black, and we do know that there is an increased risk of FSGS in the African American population, and part of that is explained by a risk allele called APOL1 that we're learning more and more about. So you might hear me refer to that risk allele. It's a little different than a genetic mutation because it doesn't guarantee that you'll get the disease. So FSGS, I know this is a busy slide. This is kind of the old way of looking at it, which is based on histology. And I can't emphasize this enough, but FSGS is a pattern of injury. So when you look at a biopsy, you have focal and segmental glomerular sclerosis. That's all it's describing. It doesn't describe the pathogenesis of the disease. This is also more descriptive. So you have classic FSGS, which is characterized by these focal and segmental sclerotic lesions with occasional global sclerosis. You have collapsing, and some of you may have been on service and seen a patient of mine that had collapsing. This is the most severe variant, and you get this collapse appearance of the glomerulus, which I'll be showing. This is associated, and both classic and collapsing are associated with this APOL1 risk variant. But collapsing is also associated with HIV and, interestingly, COVID-19. There's been a really interesting paper where it was a case series of patients with COVID-19 that had sudden onset nephrotic syndrome and acute kidney injury, and they're now calling it COVAN. I think that's fun, but not for the patient. But it's the risk of developing COVAN and HIVAN is higher if you have this APOL1 risk variant. Again, and I could do a whole lecture on APOL1, but essentially it increases the risk of podocyte injury and is more common in the African American population. So tip lesion, generally this is thought to be a little bit easier to treat than the classic NOS FSGS lesion. Perihilar, I put this up here because when you see this lesion, the scarring occurs at the vascular pole, and it's often associated with renal hyperfiltration or secondary forms of FSGS, which are really important to delineate, especially when we're talking about treatment. So this is from the KDIGO guidelines. Patients with a FSGS lesion on kidney biopsy, the first thing is to really think about what they're presenting with. So if they present with nephrotic syndrome, where they have proteinuria greater than 3.5 grams, they have an albumin less than 3, and you have diffuse foot process effacement on the biopsy, it's more likely primary FSGS. So you would treat with immunosuppression. If there's no response to your typical treatment, then you might want to consider genetic testing, which we actually have more and more available in clinic as time goes on. So a lot's evolved in the glomerular disease world, as well as other areas of medicine because of the ability to do genetic testing. So in the absence of nephrotic syndrome, so if the albumin's normal but the patient still has nephrotic range proteinuria, so they may have greater than 3.5 grams per day, but their albumin's 3.5, then, or if they have subnephrotic proteinuria, you want to evaluate for a secondary cause. So you can consider genetic screening when appropriate to exclude genetic forms. You don't want to start immunosuppression in some of these secondary cases because it's unlikely, well, it's not to benefit the patient, and then you're exposing them to the risk of immunosuppression. But sometimes it's hard to tell. So you monitor, and if they worsen, then you kind of throw them in this category if they really kind of develop full-blown nephrotic syndrome, despite conservative treatment. So it's very nuanced. This is the classic FSGS lesion. So you have a segmental lesion. This is it in kind of cartoon form. So you have an area of the glomerulus that looks fairly normal, and then an area that's scarred. This is the collapsing lesion. And this is interesting because all the capillaries kind of collapse on themselves. And then there's kind of this open area. This is the tip lesion. The glomeruli look pretty normal, or the glomerulus looks pretty normal, except for this one little area of scarring. And then this is the perihilar. So this is scarring right around the vascular pole. So the probability of renal failure is mostly dependent on the histologic classification in the setting of collapsing. So this is collapsing right here. The solid line you can see has the worst prognosis. Tip, which is this kind of bigger dotted line, does the best. NOS is right there beside that, and perihilar. So really collapsing is the most aggressive form and worst prognosis for our patients. So treatment, if someone has idiopathic, if we think they fall in that category and don't have a secondary cause, prednisone is typically the first line treatment, although sometimes I will use a calcineurin inhibitor, cyclosporin or tacrolimus if there's a contraindication. Or steroid, if someone's steroid dependent, having trouble titrating off or frequently relapsing, you can use a calcineurin inhibitor in monotherapy or in combination with a reduced dose of prednisone. And this is why really we're trying to achieve some form of remission in these patients. So if patients have no remission of proteinuria, they're much more likely to develop end-stage kidney disease. So this is renal survival, and you can see patients with no response have the worst renal survival, not surprisingly, but you have to do studies to show this. Patients with a partial response have better renal survival, significantly better than patients that don't respond at all, but the patients with complete response, of course, have the best renal survival rates. There are a lot of secondary causes of FSGS. So primarily hyperfiltration and stretch on the podocytes is a big category. This can happen if you have a solitary kidney, or if you had a kidney taken out for malignancy, or if you had a nephrectomy at some point. Obesity is on here, although we have a lot of obesity and we don't necessarily have a lot of FSGS, so it's probably obesity plus some other risk factor that we're still trying to figure out. Reflux interstitial nephropathy can cause that segmental scarring, so it can look very similar and have that pattern. Anything where you have extensive nephron loss or reduced nephron mass. So another category that we're seeing more and more is people that were born very premature, since more babies are surviving severe prematurity when they get to adulthood. They have less nephron mass, and they can get a secondary form of FSGS. Viral infections, we talked about some of these. I should add COVID to the list. Toxic agents and ischemia. And this is where I put in the hypertensive nephrosclerosis. So sometimes these patients, while they usually have a global sclerosis, sometimes they can have a segmental pattern. And this is very common in African Americans, likely related to the APOL1 risk variant. And also calcineurin inhibitor toxicity, which is interesting because we use calcineurin inhibitors to treat primary FSGS. But this is more kind of long chronic use, sometimes in transplant. So here's another question. This is one that you might see on your board exam. So a 29-year-old gentleman with HIV, and he comes to clinic, has had numerous opportunistic infections, was recently treated with a course of IV acyclovir. He's also positive for Hep C. He has 2+ pitting edema to the knees, and the remainder of his exam is normal. His creatinine is elevated at 1.8. 6 months ago it was 0.9. His albumin is low. He's got 4+ proteinuria, oval fat bodies. They love putting these on test questions. Complement levels are normal, and the CD4 count is low, and then HIV viral RNA is positive. So which of these do you think is the most common cause of his renal dysfunction? And these are your choices. Is anyone going to speak up? Maybe? So this is classic for HIVAN. So you have someone with HIV that has a high viral load, low CD4 count, that presents with nephrotic syndrome. So interestingly, HIVAN's mostly reported in patients that have uncontrolled HIV. So if a patient has a negative viral load and is on antiretroviral therapy and doing very well and presents with nephrotic syndrome, don't ever assume it's HIVAN. You got to biopsy a patient. And I had a patient that kind of met that category of very well controlled HIV, and he ended up having PLA2R positive membranous nephropathy. So patients don't always read the book, but this is kind of the classic case, and they gave you all the hints. So another question, a 42-year-old woman who's evaluated for minimal edema. So they give you that she doesn't have a lot of edema. That's another hint. But she has 5 grams of protein excretion in 24 hours. As a child and young adult, this is why history taking is very important. She developed frequent urinary tract infections. She underwent a surgical procedure to reimplant the ureters in order to prevent urinary reflux. Her blood pressure is 140/95. There's trace pretibial edema. The remainder of the exam is normal. Her creatinine is 1.5. She does have some cholesterol elevation. Albumin's 3.4, slightly low, but not terribly low, not less than that 3 that we saw as a cutoff earlier. And she has 3+ protein. So what do you think her most likely condition is? Anyone? Okay. So she probably has FSGS on biopsy, but she has a secondary form. So would we want to treat this patient with prednisone? Probably not. It would do more harm than good, because she would probably, this is from scarring from her reflux, not from an autoimmune injury to the podocyte, which we think of as the cause of the idiopathic FSGS. So she probably would not respond to steroids. It would probably make her miserable. So we want to be really careful to delineate primary FSGS from secondary causes. So I have another clinical case. So I think clinical cases are the most fun. This is not a question. This is actually a patient of mine and how he presented in my clinic. So actually presented to the hospital when I first saw him. So 48-year-old gentleman, no significant past medical history, presented to the hospital with just diffuse edema and anasarca. Blood pressure is 125/70, 3+ pitting edema, body wall edema, creatinine is 0.9, albumin is 1.8, and your analysis shows 4+ protein. The complement levels are normal. HIV, hepatitis panel is negative. SPEP is negative for a monoclonal protein. 24-hour urine collection demonstrates 17 grams of protein. So does everyone think this patient needs a biopsy? Yeah, 17 grams of protein, that's a lot. So this is the Jones-Silver stain on light microscopy. And if you look really closely, you can see some little holes in the basement membrane and spikes. This is the IgG staining. This is PLA2R staining. So that patient has membranous nephropathy, and membranous nephropathy is kind of the third most common cause or not the third most common cause, sorry, backtrack. It's the third disease I wanted to talk about. It can be one of the most common causes of primary nephrotic syndrome in adults. So it's differentiated from minimal change or FSGS because in those diseases you don't have immune complexes, you don't have IgG depositing. So we know it's an autoimmune disease, and in 70% of patients it is caused by antibodies to the phospholipase A2 receptor. So that's the target antigen in the kidney. And what's really exciting about this discovery, so this was in 2009 that this paper was written. I was actually, what was I doing in 2009? I think I just finished my residency. I was starting my chief year, so 2009 to 2010 I was chief resident. So when I was in your place, we didn't even know about this. So a lot has changed since that time. And now, not only can we stain on the biopsy, but we can check serial PLA2R levels. And it's really exciting because we can detect that someone's responding to treatment before some of those clinical responses are present. So a patient may remain nephrotic for a period of time while their PLA2R becomes negative. And in the old days, old meaning when I was a resident, so back then we might think, hey, this patient's not responding to therapy, I'm going to switch and provide them with this other toxic therapy. And now we have a biomarker that really helps us see if someone's responding to therapy. So this really was a big deal when it came out in the New England Journal of Medicine. And I'd like to point out some of my colleagues, Dr. Klein, Dr. Cummins, he was a grad student at the time, he's now a PhD in nephrology, and Dr. David Powell, who were all part of that discovery, because it happened here at U of L. We don't talk enough about all the research that's happening here that contributes to medicine. So the discovery of this really changed how membranous nephropathy is treated and followed. And like I said, about 70% of patients with membranous nephropathy have antibodies to PLA2R. And you can order them at U of L Hospital. It's a send-out test. You can order them from Quest Lab. If anyone has a question about ordering them, you can feel free to ask me. I actually order them as part of my workup for nephrotic syndrome. So, like I said, 70% of patients have this. And what's really interesting is, they were looking for, because membranous nephropathy is associated with secondary causes. So in primary membranous, and then this is a different study from the original one. In their cohort, 80% of patients had antibodies that were in this idiopathic category. Very, very small percentage of patients with lupus membranous or class 5 lupus. had antibodies, hepatitis B related, malignancy related. So there might be some overlap between PLA2R antibodies, and it does not rule out malignancy completely. So it is important that patients diagnosed with membranous are up to date on all their cancer screenings. Yep.
Were those like after the diagnosis confirmed with nephrotic syndrome, or like?
That's actually a great question. So if I have someone that comes to my clinic with new onset nephrotic syndrome, I order it as part of the initial screen. And there is a push that if someone has a normal kidney function, like normal function, and they're PLA2R positive, that you don't need to biopsy. There's some controversy. I have done that. Actually, I have one patient that she was a Jehovah's Witness and was a little anemic, so biopsy was considered kind of high risk, and her kidney function was normal. She had a very high PLA2R antibody titer, so we just treated her without a biopsy. So there are, obviously, it's a case-by-case thing, but these are so specific to membranous nephropathy that in the absence of, something that's, an outlier, really abnormal kidney function, I would consider treating someone just based on the antibody alone. Which does save someone a biopsy. I have another patient that was undocumented, and biopsies are actually really expensive procedures, and sometimes you try to find out how inexpensive you can make it, but it's still cost prohibitive. And I've had a patient like that I treated empirically as well. So there have been cases where I get the antibody and okay, this is membranous, and go ahead and treat. So really good question. So in all of these diseases, proteinuria, the worse it is, the less kidney survival. So some patients with membranous do present with subnephrotic proteinuria, although most commonly they do present with nephrotic range. Secondary causes of membranous, and I have starred malignancy on here because this is a favorite test question. Given the age of these patients, a lot of them have not necessarily been up to date with their cancer screening, so solid tumors are most likely associated with a secondary form of membranous. And it is really, really important that if you have a new diagnosis of membranous, whether it's PLA2R negative or positive, that the patient undergoes age-appropriate cancer screening. Hematologic malignancies can be associated, much more rare. They're more likely to be associated with minimal change disease. SLE's on here, but we'll talk about that next week. That's called class 5 lupus nephritis. A lot of drugs. Hep B more commonly than Hep C. Hep C is more associated with MPGN, which we'll talk about next week. Syphilis, actually, one of our former residents who then became a nephrology fellow, and actually is now a nephrology attending. I'm showing my age here. He presented a case that went to a national meeting on, and actually ended up being published on a PLA2R positive patient with membranous and syphilis. So the treatment, obviously you want to rule out secondary causes. If it's primary, you treat by risk. So if someone's low risk, meaning they have a normal eGFR, they have subnephrotic proteinuria, you can do conservative management with RAS blockade. If they're moderate risk, so they have nephrotic range proteinuria, and you can do a trial, so they should have a normal eGFR, but you can do a trial with ACE or ARB therapy to see if they become subnephrotic for up to 6 months, but if they're not responding, you want to treat them. High risk are patients with proteinuria over 8 grams, so the moderate would be between 3.5 and 8. These are some of the other criteria, and very high risk are patients with life-threatening nephrotic syndrome and rapid deterioration of kidney function. So the treatment, like I said, really depends on risk. So with low risk, you can wait and see and just do conservative management. With moderate risk, you can wait and see, or you can use rituximab or calcineurin inhibitor plus or minus glucocorticoids. High-risk patients, rituximab or cyclophosphamide with plus glucocorticoids. This was called the Ponticelli regimen, although there's been some modification of it. Or calcineurin inhibitor plus rituximab. And then very high risk, we still kind of revert to cyclophosphamide and steroids. So this is after you've decided that the patient has primary, after you've ruled out secondary, especially malignancy. And like I said, about 70% of patients are PLA2R positive, so you can follow those levels as you treat the patients. So depending on what you decide to treat first, they're not responding to that initial treatment, then you can change your treatment. But I only do that in the setting of where the antibody's not going down. So if you come to my clinic, you'll definitely see patients that get these antibodies checked at their clinic visits, and I make a determination based on that of whether to treat or not. So I know we're running low on time, so I'm probably going to stop with this question. And this is kind of another classic board style question. So you have a 65-year-old gentleman with low albumin, hyperlipidemia, and proteinuria that have developed over 1 year. 1 year ago, he underwent squamous cell lung cancer resection. And on physical exam, blood pressure is 150/90. Exam reveals normal S1, no rubs or gallops. Pulmonary exam shows decreased breath sounds, consistent with his previous surgery. And there's 3+ lower extremity edema. His creatinine's 1. He has 15 grams of protein in 24 hours, so I think we can all agree he's nephrotic. Chest x-ray reveals a new nodule in the left upper lobe. Which of these is the likely diagnosis? So come on. I've basically given it to you guys. So C, yay, you guys are awake. Maybe the post-lunch, sleepiness is starting to wear off finally. So yeah, this is a very classic boards question. Membranous, like if you see solid tumor and nephrotic syndrome, you should really think about membranous nephropathy. So hopefully, and I just have one more question, but I think this was similar to the other one. So this was another renal vein thrombosis question. I don't know why, but they love those. I mean, it's pretty rare to see. I've only seen like 1 case of renal vein thrombosis from nephrotic syndrome, but it's something that boards love to ask. So, and it's usually associated with flank pain and microscopic hematuria. So that's the big difference between that and a kidney stone, which would have gross hematuria. But so I don't want to go over. I know that was a lot of information. Luckily, I get to be back here next week to talk about the nephritic syndromes and some of the RPGN and my favorite disease, lupus nephritis. Not my favorite disease. This disease I like to study. I shouldn't necessarily call things my favorite disease. I don't want patients to get it. But hopefully you guys learned something, and I'm excited to be able to talk about these rare diseases.